Voices of Wisdom, TIRO's podcast designed to share thyroid cancer pearls of wisdom from clinicians for clinicians. Think of it as a fireside chat where we talk to international experts who share their wisdom, offering practical advice to clinicians in a variety of common and sometimes complex clinical scenarios. I'm your host, Dr. Dana Hartle. I'm an otolaryngologist and head and neck surgeon at the Gustave Roussy Cancer Center in France. And it is a pleasure for me to welcome you to TIRO's Voices of Wisdom podcast. I will be hosting this second season of Voices of Wisdom, stepping into the shoes of Dr. Janice Pasieka, who pioneered these podcasts. I want to take this opportunity to thank Janice for all her hard work on making these podcasts a reality, and congratulate Janice and all of those who contributed to the success that they have become. We created this podcast to provide clinicians with short, easy-to-digest highlights of clinical issues that we all face while treating thyroid cancer patients. Our aim is to share evidence-based information as well as practice-based experience and tips from world-renowned experts. In each episode, I am joined by distinguished international guests who bring their unique perspective and expertise to the discussion. So whether you're a surgeon, endocrinologist, pathologist, medical oncologist, or a nuclear medicine specialist, this podcast promises to be a pivotal resource in your quest for knowledge in the care of thyroid cancer patients. In today's episode, we're joined by Dr. Lisa Orloff to explore practical tips and expert insight on using ultrasound in thyroid cancer care. From identifying suspicious lymph nodes to assessing nerve involvement and overlooked neck regions, Dr. Orloff shares real-world guidance that every thyroid clinician should hear. Dr. Lisa Orloff is a leading expert in endocrine head and neck surgery at Stanford University, where she directs both the Thyroid Tumor Program and the American Head and Neck Society Fellowship, a pioneer in head and neck ultrasound, especially in thyroid cancer. She's the editor of the textbook Head and Neck Ultrasonography, and holds leadership roles in the American Head and Neck Society, the American College of Surgeons, and the American Thyroid Association. So let's get started. Thank you so much, Dr. Lisa Orloff, for being on the show today. I'm very honored and just so happy to have a very good friend and a renowned clinician, renowned professor, renowned teacher on the show today. So Lisa has a particular expertise in ultrasound for thyroid cancer. So I'm going to really have fun asking you all kinds of really difficult questions.
Well, Dana, before we start with the science of it, it's just a privilege to have this conversation with you. I always enjoy chatting with you about our favorite topic, thyroid care, but about everything else under the sun. So this is going to be hopefully as fun for the listeners as it is for us to chat.
Oh, I'm sure it will. So, let's jump right in. First of all, you've earned so much experience in radiology and in ultrasonography. And so I was wondering, in your opinion, for somebody to become an expert in thyroid ultrasound and thyroid cancer ultrasound, are there specific requirements? Are there things that we need to know and we need to do, or is it just experience? What kind of training would you think a physician who wants to get into this needs? A non-radiologist?
Yeah, well, as you alluded to, I think experience really is a relative term, and it's all important in practicing ultrasonography. Expertise is a subjective term. No matter how much one practices or uses ultrasound, there's always the potential to learn and to improve. I'm learning new things every day, even 20 years into my use of ultrasound. And I think that what makes for the greatest accuracy and insight that you can glean from doing ultrasound exams is feedback. And what I mean by feedback is following patients over time and seeing what their outcomes are, seeing what the results or the evolution of their treatment and their disease is, and how you interpreted it, and whether your interpretations were accurate or not. Being able to follow patients over time and observing stability versus change is really helpful to understand whether something is threatening or not, or is more suspicious versus less suspicious. Correlating ultrasound findings with other results or facts that you may know about the patient, including biopsy results, not just doing an ultrasound-guided FNA, but then seeing what the outcome of that FNA was, and then seeing what the surgical outcome of that FNA was, that kind of thing. So correlating surgical pathology results with what you originally saw on ultrasound. Those are the things that I think really allow one to develop so-called expertise or improvement in their ultrasound skills. And I think for clinicians who want to do ultrasound exams, they are in a much better position to be able to correlate physical findings and other test results, thyroglobulin levels, for example, CT and MRI findings, PET CT findings. So they have the most information about the patient. I really admire radiologists who do such a wonderful job of interpreting ultrasound more in a vacuum. But as clinicians, we have much more knowledge about the patient. We see their evolution over time. And as surgeons, we really get to see their three-dimensional anatomy too. So that helps us be better ultrasonographers.
That's really neat. So that's a really tremendous argument in favor of the ultrasound specialist being from part of the therapeutic team, whether it be the surgeon or the endocrinologist or a radiologist, to get that feedback and to see the ultrasound in the setting of the whole disease and the patient.
Yeah, I think that you come to the ultrasound exam already knowing a lot more about the patient. You have a sense of what you're looking for, but also of what the patient has been through. And even if somebody who's managing a patient doesn't have a lot of experience or confidence in their ultrasound exam, they can gain some basic information when doing an ultrasound exam, such as, the size of a nodule or a mass, or the location, the laterality, whether there's obvious large metastases, for example, even if somebody's not very confident in their lymph node assessment. And, we all have to start as novices at some point, and we grow from there. And it's never too late to start, and it's never, you never stop learning.
That's the beauty of it. That's maybe why we got into medicine.
Yeah.
One of the reasons.
Yeah.
Well, so to get to nodules, then we all know that we need to use the ultrasound classification of thyroid nodules in terms of risk and in terms of when to indicate fine needle aspiration biopsy. But once the diagnosis of a cancer in the thyroid is made, do you do a new ultrasound preoperatively? And what specifically are you looking for?
I do. I personally perform a new ultrasound when I evaluate a new patient in the office. And when I take a patient to surgery, I do a pre-incision ultrasound as well for a number of reasons. First of all, ultrasound does not involve any radiation. So that's, thankfully it's harmless to the patient. And it is, in all the things we do within medicine, it's probably the least cost negative. So there really isn't a lot of downside to doing it, but I do it to confirm or to reinterpret or augment what was documented previously. And I think quite often I disagree with some of the interpretation that I read in an ultrasound report in a patient that comes to me. I do it to see the window of anatomy or pathology that's relevant within the background of the neck. So to get the pathology in the context of the regional anatomy. I do ultrasound not just to identify pathology, but to recognize the relationship of that pathology to the adjacent anatomy, and to be in the mind of a surgeon, to be thinking about how I'm going to approach that pathology. And that includes identifying certain landmarks and anatomic variants that the patient might have, such as vascular findings that would indicate the pathway of the recurrent laryngeal nerve, or whether it's a non-recurrent laryngeal nerve, for example, to see whether they have a dilated thoracic duct, to see if their vagus nerve is adherent to a lymph node metastasis, to see where their omohyoid muscle is in relation to their lymph node metastases, to sort of assign a level of disease, assign it to level 4 versus level 3 in the neck, that kind of thing. But I also use ultrasound to do a laryngeal exam. And I think it's been something that, you're right there examining the thyroid. It's so easy to at least attempt to examine the larynx. It's not successful in every patient, but it's a preliminary look at whether you can assess vocal fold mobility. And sometimes it's a really good view that enables you to document symmetry and full range of motion of the vocal fold. So, it really accomplishes a lot of things that are beyond what is in a standard radiology-derived ultrasound report or exam. And, I think ultrasound exams done in radiology departments, as I mentioned, I admire and respect radiologists for being able to interpret them even without all the information that we as clinicians come to the patient armed with. But often ultrasound exams are performed by sonographers or technicians, and the official interpretation is performed by a radiologist who doesn't even see the patient. And this can result in a missed opportunity to correlate physical findings or do scanning maneuvers that are really valuable as an interactive exam with the patient, such as rotating the ultrasound transducer to a plane that's not the classic transverse or longitudinal plane, but looks at things from a different angle, or to ask the patient to, for example, to swallow during the exam to see the inferior border of the thyroid better than you can see it at rest, or use your non-transducer hand to palpate a mass and see if it's fixed to an underlying structure. All of those things are things that are part of an interactive ultrasound exam.
That's amazing. Well, talking about the interactive, I guess gets me to some specific things, like how about extrathyroidal extension? Do you look at that?
Yeah, so extrathyroidal extension is often suspected based on just the margin appearance of a mass on ultrasound, and that could be derived from a static image. But from an interactive or dynamic image, it's possible to manipulate the tissues with respect to a tumor or a mass and see if those tissues move with the mass as you press on the mass, or if they slide against the mass, indicating a lack of invasion or a lack of adherence. So that's kind of an example that's very useful when assessing the interface, for example, with the carotid artery or with the strap muscles, both of which are very commonly in contact with a thyroid tumor. On the other hand, it is admittedly a limitation of ultrasound to be able to assess structures behind air-filled, viscous or bony or cartilaginous structures. So it really is difficult to see things within the tracheal airway or the esophageal lumen, but you can still evaluate the interface between the border of the tumor and wherever it contacts the exterior of the trachea or the exterior of the esophagus. So for me, that's enough of a clue to prompt me to order cross-sectional imaging if I have any suspicion of invasion. And I do rely very much on cross-sectional imaging for invasive disease.
You talked a minute ago about being able to sort of predict some variants of the recurrent nerve with ultrasound. So first of all, first question, is it possible to see the recurrent nerve on ultrasound? And then, well, what do you look for in terms of the recurrent nerve? I'm going to let you answer that.
Well, I have never seen recurrent laryngeal nerve in the presence of a thyroid. I think the thyroid really is blamed for making the evaluation of the central neck very limited with ultrasound. And that's true to a point. The thyroid takes up so much of the space of the central compartment. But in the post-thyroidectomy neck, I have, on a few occasions, in very thin patients after a thyroidectomy and central neck dissection, seen a little tiny recurrent laryngeal nerve that I can trace up to the larynx. So I think technically it's possible, but in general, we just assume that you can't see the recurrent laryngeal nerve. So you look for other clues as to whether it would be involved in disease. And like we mentioned earlier, assessing the larynx is one way to assess for laryngeal nerve involvement by tumor. And often, even if you can't see full range of motion or full view of the laryngeal anatomy, you can detect asymmetry of motion enough to prompt you to do additional laryngoscopy, for example. But other clues about the laryngeal nerves, there's presence of tumor at the posterior border of the thyroid, especially in the region of the tubercle of Zuckerkandl, or presence of tumor at the level of the expected ligament of Berry, just below the cricothyroid joint, and that could clue you into the likelihood that there are nodes along the course of the recurrent laryngeal nerve, and if they haven't already affected the nerve function, they would certainly increase the risk of nerve damage or nerve compromise during central neck dissection. And we are aware that a non-recurrent laryngeal nerve is very uncommon. It's said to be only about 1% of laryngeal nerves, but it's so easy to detect the branching of the brachiocephalic or innominate artery into the right common carotid artery and the right subclavian artery. It takes literally just a couple of seconds to identify that branching pattern. And if that pattern is absent, one can be clued into the likelihood of a non-recurrent inferior laryngeal nerve. So it's just so easy to do that I make it a habit to check that.
That's actually helped me quite often. Our radiologists look at it now, and it does. It saves you a little bit of time and a little bit of stress in the OR. That's cool too, definitely.
Yeah, I think it's even when there's a retroesophageal subclavian artery seen on CT scan, it's not always called by the radiologist if they're not focused on that part of the anatomy. And so if you don't see that branching of the innominate artery, it might be that it's just below the clavicle and not visible in the field of view, but it can be correlated with a cross-sectional image or just prompt one to be more prepared for that possibility, during surgery.
Definitely.
Yeah.
So you were talking about lymph nodes and bulky lymph nodes. Are there different classifications or criteria that you use particularly to describe suspicious lymph nodes? And then what do you recommend in that case?
Yeah, there are, classically speaking, malignant lymph nodes have certain features that distinguish them from benign lymph nodes. And these include a more rounded shape compared to the more flattened or oval benign lymph nodes, the presence of heterogeneous echotexture in the interior of the node, such as hyperechoic or solid tissue that's different from the background lymph node echotexture, presence of calcifications in a node, cystic change in a node, irregular borders that might indicate extranodal extension, and enlargement of lymph nodes, which by itself isn't necessarily suspicious, but the larger a lymph node gets that's malignant, the more rounded it tends to get. So these features on black and white ultrasound, and then adding color Doppler or power Doppler and seeing that there's diffuse vascularity in a lymph node versus either absence of vascularity or a hilar pattern of vascularity. All of these things are very helpful in a cumulative suspicion of malignancy. And I find it really helpful when starting out on a neck exam to get an overview of the patient's lymph node morphology, because patients have a personal sort of lymph node style, if you will. Some people have very thick, fatty highlights in their lymph nodes. And if you look at just one lymph node in isolation, you might think that it's really abnormal. But if you scan through their neck and you see that all of their lymph nodes, or all the visible ones, tend to have sort of thicker hyla, that's very helpful in not overcalling a node as suspicious. Other people have really just prominent lymphadenitis or very reactive lymph nodes with big, juicy lymph nodes, especially up in level 2, where the nodes can get quite large. And just getting a sense of what their background lymph node status is helpful. And another thing that's really helpful is scanning not only the thyroid, but the central neck, and getting a sense of whether there's Hashimoto's thyroiditis present. Hashimoto's is such a challenging situation because there are often many inflammatory lymph nodes in the central compartment, and they can be easily confused with malignant nodes. And it's very hard to tell the difference sometimes, but just getting that clue that there may be Hashimoto's present is really helpful. So those are sort of patterns that you might recognize from one patient to the next. After you have that sense of the background, it's easier to detect outliers or lymph nodes that look different than the rest. I think when you identify suspicious lymph nodes, it's not mandatory to biopsy every suspicious lymph node. I think if you are working up a patient for thyroid cancer and planning treatment, it is sometimes sufficient to biopsy a suspicious lymph node to get a diagnosis of metastatic thyroid cancer, such as papillary or medullary carcinoma, and that could obviate the need to biopsy the primary tumor. But I think before performing a biopsy, you have to think about what the results of that biopsy would do in terms of influencing management. If it's a very small lymph node, it may not warrant intervention at the point in time where you're seeing the patient. And I think it may be better to just monitor that lymph node over time, see if it grows rather than rush to biopsy it. But you can also correlate abnormal lymph nodes with things like serum thyroglobulin levels or calcitonin levels or scan results from a radioactive iodine scan, that sort of thing. So it's helpful to recognize and document lymph nodes, but it's not always mandatory to biopsy them.
That's very wise words of wisdom. And again, this, like you said initially, look at the ultrasound in the context of the pathology and what's really going on and what we need to know and want to know.
Yeah.
So in your experience with thyroid cancer, are there any particular regions in the neck that radiologists tend to overlook? Are there some trick areas or some key neck levels or particular areas in the neck where you really want to look at? And that's particularly thyroid cancer. I guess that's my idea. It's not just the neck levels as they're defined, but are there areas that you look at particularly?
Yeah, and I'm glad, Dana, that you brought up just the term levels, because the classification of neck levels is slightly different on ultrasound than it is cross-sectional imaging. So we define the boundary between level 3 and level 4 on ultrasound as where the omohyoid muscle crosses over the internal jugular vein. Whereas on a CT scan, it might be the level of the cricoid cartilage. And so I mention this because something that's called level 3 on a CT scan might actually seem to be in level 4 to the ultrasonographer. And so it's important just to recognize that the levels might be different depending on how you're looking at them, and how you plan your surgery could be influenced as well. But the areas I think that are common problem areas, or places that sometimes get overlooked or just under evaluated, are the entirety of level 6, first of all, not just immediately adjacent to the thyroid, but really scanning all the way down as low as you can possibly go in the paratracheal space, which requires tilting the ultrasound transducer to look behind the clavicles and the sternum to some degree as much as possible, really all the way down to the innominate vessels, or even lower in really young flexible patients. But the lowest limit of level 6, and then up above the thyroid in the prelaryngeal space, looking for prelaryngeal or Delphian lymph nodes, looking for a pyramidal lobe that's involved, or distinguishing a pyramidal lobe from a metastatic lymph node. I like to go all the way up to the tongue base, because I've discovered that a lot of people have incidental thyroglossal duct cysts that are just never recognized. And that may or may not matter very much in the big scheme of things, but sometimes it accounts for radioactive iodine uptake in the upper midline of the neck that might not have been explained otherwise. And so that's in the central neck. But in the lateral neck also, again, going very low in level 4, all the way down to the pleura, the cupola of the lung, around and even inferior to the subclavian vessels. That's a common area to get missed. And I think medial to the carotid sheaths as well, in the sort of paralaryngeal space. That's one other spot that, unless you really look for it, you can miss lymph nodes between the carotid artery and the larynx. And sometimes to see that area, you have to ask the patient to turn their head and even sort of slightly push the larynx away from the soft tissues. But lymph nodes can hide in that space that corresponds to where the superior thyroid artery and the vascular pedicle would drain the thyroid. So it's an important area that I think needs to be you need to proactively look in that area.
Yeah, great. That's a great take-home message, because those are areas that we miss as surgeons, those low-lying areas in the level 4 and 6, and then we don't necessarily go and look in the lateral laryngeal area either. So that's great to good take-home message. When you're following up a patient who's already had surgery, neck dissection, are there any tips? Again, any other particular regions you're looking for? Are there any particularities during follow-up?
So it is easier to perform the ultrasound exam in the post-thyroidectomy neck. So again, it's often been said, oh, you can't evaluate the central neck in the presence of the thyroid. And I disagree with that. You may not get complete evaluation of the central neck, but you can often recognize pathology or suspicious findings that would prompt you to really scrutinize areas during surgery or expect to find nodes underneath or compressed by the thyroid. But once the thyroid has been removed, it's actually a much less busy space. There's easier access to the central neck. So doing the exam in follow-up of patients is easier. It's less time consuming, generally speaking. On the other hand, you're wanting to document findings so that you can compare them over time. So sometimes it's a little bit tedious to sort of identify and document lymph nodes that may not be particularly suspicious, but you want to know sort of where the patient's new baseline is. And so, evaluating the central neck, but also the lateral neck is essential, in my opinion. So much so, I think that this is a generally agreed upon principle, but in my role in the development of the new American Thyroid Association guidelines for thyroid nodules, we advocate ultrasonography of the thyroid really being synonymous with ultrasonography of the thyroid and the cervical lymph nodes. So it's important to look not only at the lymph nodes in the central compartment, but in the lateral neck compartments as well. And what's nice is patients have general symmetry or pairing of structures, so it's easy to compare the right side with the left side, and that helps one to get a sense, again, of normalcy versus abnormality of findings, so that the patient's sort of their internal control to some extent.
That's fascinating. But to conclude, do you have any other take-home messages, other words of wisdom for us with your experience in thyroid ultrasound?
Boy, well, I guess my first advice is just do it. The more ultrasound practice you have, the better you get at recognizing the spectrum of normal and then the spectrum of abnormal. And I think for a lot of people, there's a barrier to adopting ultrasound because it's time consuming. Also, there's a fear of missing something. And to that, I would just say that even getting started doing the exam in an informal way is invaluable. You don't have to document or formally compose an ultrasound report. You can still use an ultrasound system to evaluate a patient's neck and prompt you to perhaps order additional testing if something is suspicious, or to help your learning curve. It's amazing how much information you can get just from running a transducer over the patient live compared to looking at what can be a very confusing picture that somebody else captured that you don't know what the context is or what the exact location is. So I do think that jumping in and trying it, there's always this epiphany of that it's a lot easier than it might look. And it's a lot more intuitive. And when you're seeing the patient in front of you and getting the context, it's easier to interpret. Having said that, I think you and I have talked about something that is a favorite tool or application of ultrasound that I think is underutilized, and that's using ultrasound guidance to tattoo structures that are recurrent or residual disease in the post-treatment neck. We all know that revision thyroid cancer surgery is more challenging than primary thyroid cancer surgery. Scar tissue is, you can recognize structures on imaging, but when you get into the surgical setting, it can be very hard to identify structures, and scar tissue causes a lot of adhesions. And using ultrasound guidance to tattoo a target with either what I use is methylene blue, I think what you use is micronized charcoal. So you can create a little color marking of an intended target, which helps to identify that target intraoperatively and facilitate the retrieval of it and confirm that you're removing the actual intended target. So that's a really useful application of ultrasound guidance and needle placement.
Well, I can say I learned a whole bunch as usual talking with you. And so Dr. Lisa Orloff says, just do it. Is that the take-home message? All right. Well, it makes me just want to go and do ultrasound right away. Thank you so much.
Thank you, Dana, as the moderator, and also express thanks to the THANC Foundation for making this podcast series available to thyroid cancer caregivers around the world. I think this is a great opportunity to chat and to discuss our respective perspectives, and I hope this has been useful for the listeners out there.
And that brings us to the end of this episode of Voices of Wisdom. I'm Dr. Dana Hartle, and it's been an absolute pleasure to host today's episode, where we explored how ultrasound can be optimized in thyroid cancer care, from diagnosis through follow-up. I want to extend a special thank you to my guest, Dr. Lisa Orloff, for spending time with me today to discuss the nuances of ultrasound in thyroid cancer care and share practical, experience-driven insight. Thank you, Lisa, for sharing your expertise and helping deepen our understanding in such a meaningful way. If you have any questions or suggestions for future podcasts, please email us at voicesofwisdompodcast@gmail.com. We have an exciting season ahead of us, so please stay tuned for future episodes. And if you liked our podcast, please subscribe to our webinars, which air live every Friday morning at 8 a.m. Eastern Time, US. TIRO Multidisciplinary Seminars is a series for thyroid clinicians and researchers that covers breakthroughs in thyroid cancer research and treatment in the form of topical journal clubs, state-of-the-art lectures, multidisciplinary tumor boards, and lively panel discussions. Just visit tyro.expert/subscribe or click the link in the description. Thank you for tuning into this episode of TIRO's Voices of Wisdom podcast. See you next time, and until then, take care and keep making a difference.